Hi, my name is Manali Kamdar. I'm an associate professor at the University of Colorado Anschutz Cancer Center. So I'm going to walk you through the Echelon-1 study. In patients with Hodgkin lymphoma, as we are all aware, the outcomes are excellent. At this point in time, our aim is to make sure that patients with Hodgkin lymphoma do not have long-term toxicity, but at the same time, we also want to continue to improve upon outcomes and efficacy. Since 1973, ABVD has been the standard of care for patients with Hodgkin lymphoma, especially the ones in stage 3 and stage 4. With ABVD, roughly about 80% of patients can be cured. However, ABVD can have long-term toxicity, and at this point in time, for the 20% of patients who will relapse, our options are there, but we would of course hope to give them the first shot of cure right away when they walk into the door. So as clinical investigators, we all aim to get them to 100%. In patients with relapsed Hodgkin lymphoma, brentuximab, which is a CD30 antibody drug conjugate, has shown excellent efficacy in heavily relapsed refractory patients with Hodgkin. So it's intuitive that in the world of oncology, we bring it forward. And with that in mind, the Echelon-1 study was designed several years ago. It was designed in patients with advanced stage Hodgkin lymphoma, so stage 3, stage 4. And these patients were randomized to either getting 6 cycles of ABVD or 6 cycles of AVD plus brentuximab. The endpoints were primary progression-free survival, overall survival. At the initial 2-year landmark, the modified progression-free survival was statistically significant and superior in favor of AVD plus brentuximab versus ABVD. In patients who received brentuximab, there was more neutropenia, there was more neuropathy. However, there was a statistically significant progression-free survival. As a result, a lot of us changed our standard of care in the clinical setting. At that point in time, an overall survival benefit was not established. And thus, this is very important to note that the 5-year follow-up analysis that looked at the overall survival benefit, it actually did show that there was a statistically significant as well as superior overall survival benefit in favor of AVD plus brentuximab as compared to ABVD. In patients with ABVD, there was about an 89% survival. On the other hand, there was a 94% survival benefit on the AVD plus brentuximab arm. It translated roughly into a 41% reduction in death for patients who received AVD plus brentuximab. At a median follow-up of 73 months, 39 and 64 overall survival events occurred in AVD plus brentuximab versus ABVD, respectively. The estimated 6-year overall survival rates were 93.9% on the AVD plus brentuximab arm versus 89.4% on the ABVD arm. There was a consistent overall survival benefit for AVD plus brentuximab versus ABVD across all pre-specified subgroups. This also translated into a 6-year progression-free estimate of 82% with AVD plus brentuximab versus 74.5% in patients with ABVD. Overall, AVD plus brentuximab had a comparable long-term safety profile to ABVD. I think a key highlight of this clinical trial is the long-term safety profile that they looked at. As I alluded to, patients who receive brentuximab, they are at a higher risk of neuropathy, which was initially seen in about 67% of patients. And of those patients, 67% had complete resolution. The long-term follow-up also denoted the same. Very few patients had residual neuropathy. Again, highlighting that the quality of life for patients with AVD plus brentuximab was superior than patients who received ABVD. As we all know, in patients with Hodgkin, there's a bimodal predisposition in terms of incidence. So we do see a lot of patients who have they are younger in age and have Hodgkin lymphoma. And clearly, we want to make sure that their long-term outcomes with regards to fertility, as well as the occurrence of second primary malignancies, can be lowered. And thus, these were the other two things that were also looked at on the long-term follow-up of the ECHELON-1 study. The net is that patients who received AVD plus brentuximab, there was a lower incidence of hematologic secondary malignancies versus patients who received ABVD. Patients did have higher incidence of relapse on the ABVD arm, and that probably equated to the eventual impact on the long-term overall survival, which favored the brentuximab arm. With regards to fertility, there were more pregnancies in patients who received ABVD, who received AVD plus brentuximab. So overall, I can say that in the long-term follow-up of the ECHELON-1 study, AVD plus brentuximab emerged clearly significantly superior with regards to a nearly 41% reduction in the risk of death versus ABVD, which has been the historical standard for patients with stage 3 advanced and stage 4 Hodgkin lymphoma. This also translated into lower long-term toxicity, especially second primary malignancy, as well as retention of fertility, favoring brentuximab plus AVD as the new standard for patients with stage 3 and stage 4 Hodgkin lymphoma.